right, good morning, everyone. Welcome to Public Health 101. Today we're going to be hearing from the COVID-19 unit. Are you guys still referred to as the unit?
Oh, trick
No?
question, Jen.
I know.
Not anymore.
I've been out of the game too long. All right, well, we have Teddy Merrick and Jamie Camella. So I'll leave it to you guys to get started.
Great, thanks, Jen. I'm going to pull up our slides and make sure that everything works okay.
Could we do quick introductions for who is here with us?
Yeah, definitely.
Since it is a small group. So who wants to go first? Amy, I know you, so I'm going to pick on you first.
That sounds great. Good morning, everyone. My name is Amy Dow. I work in the Center for Emergency Preparedness and Response, and I'm the Community Initiatives Coordinator, and excited to hear more about the Center for COVID-19 Epidemiology today.
Great. Welcome, Amy. How about Judith?
Hi, I'm Judith Hahn, and I also work in the Center for Emergency Preparedness and Response as a contractor.
Okay, great. John?
Hello. I'm an intern working in the Adolescent School in Reproductive Health branch of RIDOH. I'm working on such stuff such as data entry for FPER forms, and I'm also working on some other side projects.
Great. With Sani?
Yes.
Great. And last but not least, Rachel.
Hi, good morning, everyone. My name is Rachel. I work in the Division of Community Health and Equity. I am their oral health epidemiologist and evaluator.
Oh, wow. Nice to meet you, Rachel.
Nice to meet you too.
So I heard a recent statistic that we have turned over a little less than half of the employees at RIDOH in the last 2.5 years. So I don't know a lot of people and haven't been back to the Cannon building all that much. So it's great to meet you. And you have some big shoes to fill. Hopefully you did get in touch with Jordan and get somewhat of a handoff, but she's great and Sadie's great. So nice to meet you.
It's nice to meet you guys too.
All right, Teddy, let's rock and roll.
All right, do you want to introduce yourself in any more detail?
Oh, sure. I'll be happy to. So my name is Jamie Camella. I am the chief of the Center for COVID-19 Epidemiology. Prior to that, I was working in the maternal and child health program for about 4 years. And then prior to that was working in infectious disease alongside Teddy in the HIV, STD, and tuberculosis program. So I have come full circle in my career over the last 10 years and glad to be back. This is near and dear to my heart, and so just excited to share our work with you. It has evolved tremendously over the past 2 years, and yeah, there's a lot of lessons learned, and we'll dig right in.
All right, and I'm Teddy. I am the Deputy Center Chief for the Center for COVID-19 Epidemiology. I've been with the Health Department for 11 years, all in infectious disease surveillance and response. The 6 years prior to COVID, I was overseeing our HIV, STD, TB, and viral hepatitis surveillance programs, both surveillance and our contact tracing programs, which is very similar to what we've been doing in COVID. So this work is very familiar to me and made sense when I was activated to the COVID response, and I've been with it since the beginning. So everybody can see my slides, yeah?
Yes,
Right,
and I'll just say we're hoping this to be more of a conversation than a formal presentation. So raise your hand if you want to interrupt at any time.
Yeah, raise your hand, put questions in the chat if they're coming fast and furious, and we can try to get to all of them. It is a bit of an ambitious agenda. I'm not going to spend too much time on it, but there's a lot that our center does, but we really want to tailor it for what people are interested in and what they might want to hear about. So we can truncate at any point and flip over to true Q&A. And we start with basically a broad overview, so you have a sense of what we are experts at talking about, because COVID is so big. So before we get to that, just a reminder for people or first time, if you haven't heard it yet, just a bit about Rhode Island. We're a population of just over 1 million. We have a small land area, something like 35 miles by 45 miles or something like that. And we have one health department. So RIDOH is both acting as the state and local entity, which is rare. And there are many jurisdictions that have local or county health departments. And so the relationship between them and the state and CDC and the public, it's all very different. And I think it makes RIDOH a very interesting and dynamic place to work, where we interface with the public and community-based organizations, and we interface with the CDC. And we are, as a department, composed of many different divisions and different centers, which we'll talk a little bit more about, but did not want to miss the opportunity to recognize many RIDOH state employees who were activated, and state agency employees from across the state that were activated to help with the COVID response at the beginning, over 2 years ago, and that many of them really helped build the foundation of what is our epidemiological operations unit, or now our Center for COVID-19 Epi. And we are fortunate to have some state employees persist with us to this day. In order to understand the work that we do, you need to understand a bit about the Department of Health's authority to do infectious disease surveillance. You may have been on Monday's presentation and heard from our sister center that oversees HIV, STDs, and TB. They may have gone over this, but just as a refresher, we have statutory authority to collect information on reportable events. So something that the Director of Health deems to be of interest can be collected by the health department without consent of that individual. What that really is saying is that laboratories or healthcare providers are required to report if they identify a case of, say, Lyme disease or measles or HIV, or now in this case, COVID. And that power is broad and is also written in a way where new and emerging diseases, such as monkeypox, also falls under this authority. And so the health department has that capability of determining what's reportable and what has to come to the health department. Just because we receive information on individuals without their consent for the purposes of surveillance and response doesn't mean that we can share that widely afterwards. And we have very strict security and confidentiality guidelines to ensure that that information is kept safe. It's the most important thing that we do. And we routinely get reports from providers that are ordering the test or treating the patient, the laboratories that are conducting the testing. And those are the common routes of reporting to our program and to many of the programs at the health department for infectious disease surveillance. But we also see that entities such as schools, veterinarians, long-term care facilities, other healthcare facilities may report to us if they suspect a case of disease or if they know somebody has been diagnosed with a disease. It's this. Let's see. Okay. So digging in a little bit more into what our center does specifically, and we'll look at the broader COVID response structure so that we can place this in the context. But just interesting details. Our center peaked at about 500 staff at the height of the pandemic, and we are a center that include many different types of professionals: epidemiologists, nurses, case investigators that are doing our interviews, data and technical support people, administrative support, program managers, project managers. Because of the size of our unit and the scope, all of the different partners that we're working with, we have broke our center into several different teams that focus on different populations. So we have a team that really focuses on the general community, teams that focus on education-affiliated individuals, so childcare, K-12, and higher ed, team that focus on congregate settings, long-term care facilities, group homes, corrections, teams that work on healthcare, work closely with our shelters, and liaise closely with our different workplaces and large employers. Our relationships with those different entities and our work in those different spheres is similar sort of across the board and really include all of these different key activities. We conduct case investigations, so we interview new cases that have been diagnosed with COVID. Historically, we were doing contact tracing or contact notification. So we were talking to those named close contacts to say, you were exposed to somebody with COVID, you need to quarantine or you should go get tested, and other mitigation efforts. Respond to outbreaks. So an unexpected increase in the number of cases in a certain place amongst a certain population in a certain time period will cause us to respond. So a number of cases at a long-term care facility or in a school will respond differently. And then outside of that sort of case level and responding to disease, we have a large part to play in stakeholder engagement. So working with our K-12 schools, having routine pod calls with the different school administrators, school nurse teachers, principals, working closely with our long-term care facilities and our regulations folks that license and regulate those entities. We receive calls from the public. We receive complaints through the Department of Business Regulation, and we do a lot of sort of outbound routine interaction with our different stakeholders to make sure that they're educated on COVID and they know what's going on. And one of the stories that we'll tell is how COVID has changed over the 2.5 years, and that nothing has ever been stable in the world of COVID. You all may know this, you may have lived it in one way or another, but every day, every week, every month, something was changing with the landscape, whether it was the type of variant, the way that it was, or how it was transmitted, or how quickly it was transmitted, or the guidance from CDC. So there's a very strong emphasis on stakeholder engagement and keeping our partners informed. And then our program, our center also does a lot in the area of quarantine and isolation support. So we learned early on that people will not isolate, people will not quarantine if they don't have a safe place to sleep, if they don't have food, if they don't have their pharmaceuticals that they need, if they have behavioral health needs, a number of things. If they have unmet needs, they are much less likely to stay home for that 7 or 10 or 14 or 20 days that was required to try to disrupt transmission. So we have a team dedicated to linking those people to the right services so that they could isolate and quarantine safely. And then we invested in dedicated training team, dedicated data management and analysis team on our side. There's an entirely different quantitative analysis team that does a lot of big data and pushing stuff out publicly, but we have our own data team in-house, and we have a team of technical experts that help us manage our Salesforce surveillance system, which we will also talk about in more detail. So next, we're going to talk about the org structure, but I wonder if anybody has any questions thus far, or Jamie, if you have anything else that you want to add to sort of layer on what we've covered so far.
Nothing from me.
All right, we'll keep rocking and rolling. So the story of our center and of the response, as I said, is one of sort of things constantly shifting and evolving. Our response started in early 2020, actually before the first cases were identified in Rhode Island. The state and the Department of Health started their response. The incident command system was set up, and early on, it was very much a RIDOH-centric response. We had our incident commander, who was, I think, Chris Goulet from the health department. A number of health department staff members were put into different places to ensure a clear hierarchy, clear reporting structure, and how to get activities completed in the area of case investigation, data analysis, communications, document development. There was a clear hierarchy and review process for everything that we were completing in the world of COVID. But actually very quickly, very early on, like the rest of the nation and the world, we found that this was a completely different beast in terms of infectious diseases. This was going to be a pandemic, and things were really going to intensify and get worse before they got better. So things shifted to what we were calling a whole of government model, or a whole of government approach. The response came under the leadership of the governor and the governor's team, and there was engagement from many different state agencies, limited to, or not limited to, but including commerce and business regulations, Department of Education. We also saw the activation of the National Guard, and they went into so many different teams and helped augment resources and make sure that the work was getting done. So we operated in that whole of government approach in many different iterations for a long time. I mean, we still are in some respects in this whole of government model, and there's a lot of external partners that continue to work with us, and we report up to the governor. But in 2022 now, fast forwarding, we've moved to this reintegration approach. And so our center and many other components of the COVID response are going to find their long-term homes in different departments or divisions. So we found our way back into the division that oversees infectious disease surveillance. And that is going to be the long-term home for COVID epidemiology, whereas previously we were operating in our own sort of COVID unit structure alongside the core health department. And to visualize it a bit more, just the scope of the COVID response, and unfortunately, some of the things that you're not going to be hearing about today, because we're only going to talk about our little piece, but I sort of drew a box around where Jamie and formerly what we were formerly known as EpiOps sort of lives. And you can disregard the testing piece, which is its own team, but we were really focused on that case investigation and contact tracing piece. And again, don't worry about the names because this is dated back to March of 2021, but we were part of an operation structure that also had a team dedicated to treatment and hospital coordination and testing and vaccinations. There was a team dedicated to community outreach, communications, working with our high density communities, community mitigation, an entire team or sets of teams dedicated to data, modeling, what's getting up on the website, advanced analytics, dashboards, things like that. And so we are one part of it, and we are operating up through our chief operating officer, our executive director, the director of health, and the whole of government sort of leadership team. And this is how we operated for a long time. And again, we'll be focusing really on that case investigation and contact tracing piece. And fast forward, now we're here. So we are a center under Chris Goulet and Dr. Bandy, who's our state epidemiologist and medical director, also the acting director of health. We operate as a center alongside emergency preparedness. Some of you coming from that center, the Center for HIV, Hepatitis, STDs, and TB, CADE under Daniela, who's currently responding to the monkeypox outbreaks, and the Center for Emergency Medical Services. And this is the long-term future state reintegrated structure for our particular center. And similarly, the data and analytics team has found a home in Chowda. The vaccine team has found a home in the immunization program, et cetera. Found or finding their way there. So then our center structure, as I alluded to, is broken into different specialty areas just for ease of management, and because there are unique needs in different pockets of our population, our subpopulations. So we do have a team that focuses on data quality and management, and then we have our community team, which is really responding to this cases that don't fall into any of the other specialty lanes. So it makes more sense to talk about those other specialty lanes. We have a team dedicated to cases and work in the education sphere. So we have a team specializing in childcare, outreach, K-12, and IHE. Similarly, we have teams dedicated to working with our congregate settings, our employers, and our healthcare partners. We have a team dedicated to that QI support piece. And then we do have clinical expertise in our center and what we call the COVID prevention field team, which actually goes out into the field and supports facilities. And then underscoring or supporting all of it is our training and quality assurance teams and our Salesforce team. So that is a rapid fire through the different org charts and a bit about the history of the response. So a key thing that we do is case investigation, and this may be familiar to all of you. Again, I mean, living through the pandemic for the last 2.5 years, I think many people who didn't know case investigation and contact tracing existed now know that it exists and may have experienced it firsthand. But it is a large part of what we do. It really is like one of the largest. I mean, our team is so large partly because of the number of case investigators that we have, this army of individuals that are reaching out to the public to support them. And so just wanted to have a little bit of background. It's a core disease control strategy. It's been around for decades. It's most commonly seen in STD programs and HIV programs where people who are diagnosed get interviewed, their close contacts are identified, and then those close contacts are reached out to. It requires good training, specialized skill, and understanding and patient confidentiality, understanding medical terms, and being able to understand the landscape of public health and medical services in the state so that you can link people to the right services, and a need for excellent interpersonal skills, rapport building, being culturally sensitive. We saw this really on overdrive in COVID, in that we were reaching out to so many people, so many different levels of, because the pandemic was moving so quickly, understanding of what was happening, what COVID was, what it meant, what services were available. Our landscape of service provision was always changing. So our case investigators were expert at always staying up to date and always being flexible and really being able to build that rapport. And in some cases, break down some very angry, unhappy, or upset people, either because of what they were going through, what their family members were going through. Again, we were going through this this sort of pandemic caused an economic, a financial, a sort of workforce problem. Many people were out of work. Many people lost their jobs or lost income during the pauses when everybody was really on lockdown and they were having a hard time finding jobs again afterwards or finding steady work. So it wasn't just people because they didn't feel well or because they had a sick family member, but also just sort of the other societal impacts of the pandemic led to some challenges with interviewing them. And it really underscores our ability to talk to people, really emphasizes how well trained and how strong our case investigators were. So primarily our program did phone-based interviews, and we'll talk a bit about our call center technology. And these interviews may deliver the result to the person. Early in the pandemic, people didn't know that they were positive until we called them and told them. That changed. Setting the expectations of the call and educating people on isolation and quarantine, and then collecting those symptoms and medical history so that we knew how long people had to quarantine or isolate for, if they needed to get tested, collecting their needs for quarantine and isolation support, and then collecting those close contacts and exposed places. Where were you in the 14 days prior to symptom onset? Where were you during your infectious period when you may have been able to transmit to others, so that we could try to figure out how transmission was happening, who was most at risk, and how to disrupt transmission. And then at some points in the pandemic, we had a monitoring system where people could get a daily text message where they could check in to say, I'm feeling okay, or I have symptoms now, or I need help with food or housing or support of another type. This has evolved over time. We began with a focus on isolating people and finding your close contacts and contacting them to disrupt transmission. As new variants emerged, the transmission moved much quicker. And we also had other tools like treatment and vaccination that were showing that health outcomes were getting better. And our outreach efforts have evolved, where now our focus is really on educating people on treatment opportunities as quickly as we could after they test positive, and educating people on vaccine, because we are commonly coming across people who test positive who haven't gotten their full series. They may not have gotten their booster yet, or they may not have gotten their primary series, or they may not have been vaccinated at all. So it's an opportunity to intervene and then link people or refer people to the right services. And our goals now is really to keep the healthcare system intact and reduce the burden of increased hospitalizations on the system. We don't want hospitals to fill up, and we also know that there's a healthcare staffing crisis, and we want to make sure that our healthcare system stays intact. So primarily we do phone-based outreach, but we wanted to identify or sort of share some of the other ways that we do outreach and some of the other things that we do outreach for, because we are more than just case investigation. We for a long time had field-based case investigators. So the state testing landscape or the state testing system was stood up, and we were doing tons of rapid testing in the community. And we actually co-located case investigators there. So after a person got tested, they waited 20 minutes for the result. If they tested positive, you can go talk to one of our case investigators right then and there. They were in full PPE, and you can get through your case interview. Then you can go home and you can focus on resting, recovering, and getting better. And we had very high success rates. Almost 100% of people that tested positive at these sites got interviewed by a case investigator. We got critical information and we shared critical educational information with them, as compared to 70-ish maybe % of cases over the phone eventually being reached. So we were reaching people faster, and we were reaching more people percentage-wise than if we were doing phone-based interviews. We also follow up with employers and venues. So if people test positive and they were on site during their infectious period, we would provide this information to an employer, somebody who was appropriate to know. We were able to disclose that information with a supervisor, a medical team at the facility or at the employer, and try to do contact tracing through them and put in mitigation efforts. For a long time, we were doing phone-based communication to our contacts to notify them to quarantine. You've been exposed to somebody. Technology allowed us to sort of advance beyond that. And then if we saw more cases in a location than we expected, so we saw a cluster of disease, we would follow up with those locations. And as I alluded to, we also respond to public inquiries and DVR complaints. So early on in the pandemic, we were getting a lot of information about, people were going to church without wearing masks, or this facility was not doing physical distancing in the way that they were supposed to. As the operations unit, we would get that information and we would deploy a case investigator or a nurse to have a conversation with leaders in that area and try to educate on the best practices. Wasn't always successful, but we did the best that we could. And then we have some other outreach components that we'll talk about a little bit later about clinically complex cases, travel response, things like that. So I am going rapid fire. I will just once again, Jamie, sort of pause for you if there's anything that you want to add. You're on mute.
I'm talking on mute.
Coffee.
That must be the phrase of the year. I'm on mute.
I'm on mute.
I think you're doing a phenomenal job. I know that there's a lot more here and it's 9:30 already. Yeah. So I think some of it will have to be read afterwards. If we can just maybe speed it up just a little bit so that we can make sure we have time for questions at the end.
Absolutely. Any questions from the audience? All right. So just wanted to provide an interesting visual. This is what our case investigation and contact tracing efforts can show us. So early or middle of 2020, we uncovered a network of transmission in Narragansett that was related to a number of different employment locations and social outings outside of business or work that these folks frequented. And we were able to outline the locations of concern, individuals who tested positive, individuals who were contacts, those places, I might have just said that, and then be able to try to disrupt transmission, right? And and learn about the disease and learn about behaviors. And so we understood people were going to work while infectious. People were going to work while symptomatic, even though the guidance said not to. People were placed on quarantine, but they were still going out and about. So we are understanding that, these mitigation strategies could work, but they needed to be adhered to, and to find ways to work better with businesses and employers to really buy into these public health mitigation efforts. And again, this was August, just after reopening. And so it was a challenging time, I think, for businesses and people. They wanted to get back out and about. Commonly what we do is produce something like this, which shows this is a transmission diagram that our epidemiologists put together that really show a timeline from the first case to subsequent cases and help to characterize, when people might have been exposed, when people might have been infectious on site, when certain, mitigation efforts like isolation and masking were put in place for people, and if we were able to mitigate spread, or if we were experiencing some ongoing transmission and we needed to do something larger. This is common in childcare, K-12, IHE, or employer and corrections facilities and congregate settings. Our EPIs are churning out these types of diagrams to understand transmission and try to keep facilities safe. So one of the keys that we wanted to emphasize is the use of data to inform operations. It really is a hallmark and a success of the whole response, and it's not something that we alone could take credit for. But with our quant team and with members of leadership, we really emphasize looking at the data constantly to understand what was happening in the pandemic, who was being served, and who may be underserved. And this slide really just serves to showcase that as we were moving away from universal case investigation and contact tracing and thinking about how outreach could be used differently to provide a service, we were looking at hospitalization rates by age group and by geography to say who's most needed to get our outreach to try to keep people safe, prevent adverse health outcomes, and keep those hospitals and healthcare centers intact and not overloaded. And what we learned is that it's not just age alone that is a predictor, that age and geography both had strong predictors into who may eventually get hospitalized. So we want to reach out to those people and ensure that they get access to treatment as quickly as possible. So the way that this played out is that we prioritize our high density community tier 1 zip codes higher than some others. So people 40 to 59 in 5 zip codes around Providence, Pawtucket, and Central Falls, while younger, had similar rates of hospitalization as 60-year-olds statewide. And so we want to prioritize outreach to those 40 to 59-year-olds as well. This informed us, and it helped us figure out a prioritization structure so that if we couldn't get to everybody, we had a sense of who were the highest priority targets to try to keep safe and healthy. And it's just one example of data being used every day. Jamie?
Okay, yeah, I just have one thing to add here. People may question why we moved away from universal case investigation and contact tracing, and I just wanted to touch on that for a brief moment. One is
you do that. I'm going to go get my water so that I don't keep coughing.
Okay, great. One is that really we saw from the science and that the incubation period had changed. So from the original virus, which had up to a 14-day incubation period, subsequent virus or variants, really that incubation period reduced to somewhere between 2 and 7 days for the most part. And so when we were using data to make that decision locally, we were saying, okay, how long does it take for someone who is symptomatic to go get a test? How long does it take for the test to result to the Department of Health? How long does it then take us to reach out to people? And often that was beyond, we saw that period of time was often longer than it would be effective for us to be doing any amount of outreach to contacts, that by the time we got them into quarantine, it didn't matter anyways, because they would already have exposed other people. So really, that was being kind of lifted up by all of the states to the national, to CDC, to the national government. And so they changed basically the guidance that said states should move away from universal contact tracing. That doesn't mean that we don't do any contact tracing. We actually work in when we have outbreaks and clusters of concern, especially in congregate care settings, we do collect those names of close contacts so we can make sure that they're tested appropriate according to guidance, and we understand secondary transmission within those high-risk environments. So just wanted to mention that, as well as the volume, especially during the Omicron surge this past winter, really quickly outpaced our ability to respond and it looks like this is perfect timing, our ability to respond to all cases effectively, and really had to think about how are we using our precious resources to do the most good. And so that's when we essentially made the switch to this, reaching out to only high-risk individuals by kind of descending age and geography. All right, back over to you, Teddy.
Yeah, I'm not going to spend too much time on this timeline, but in October of 2020 is really when we got our, well, after the initial wave, October 2020, we got hit hard. And that's when 50 additional state employees from around the state, all different agencies, were activated. And we started huge pushes to recruit, onboard, and train people to create this army of case investigators and contact tracers. And that even just like pales in comparison to what we experienced during the Omicron wave in December 2021 and January 2022. We thought 400, 500 cases a day was, the darkest days. And yet here we were with 6,000 cases a day. But of course, we also had vaccination and treatment options that really changed the landscape. And so all of that had to be taken into consideration when thinking about what our outreach and what our intervention really looked like. So you can peruse this in more detail later. So, I mean, that's even early on, we could tell that volume and the needs in the community were going to stress and maybe overwhelm existing public health infrastructure and the ways that normal ways of doing case investigation and infectious disease surveillance. And so necessity is the mother of invention. So we were very fortunate to have innovative leaders and engaged leaders, Governor Raimondo and her team, to push for new ways of doing things. And so we use Salesforce as our surveillance system. And I wanted to spend a little bit of time reflecting on how phenomenal of a system this is and tool, and how it changed the way that we do surveillance and response. So we get most of our lab results electronically directly into Salesforce or into Salesforce via NEDS, which is the surveillance system that other infectious diseases use. But what happened during COVID is that we really, I mean, it was like warp speed that we got laboratories and facilities on board to report to us. It was moving more at a snail's pace prior to COVID, and then it just went like that. And that was really impressive. We started to break down, you have to send it in this format. It's kind of like, get it to us however you get it to us, and we're going to get into the system, allowing us to move quicker to respond to cases and help keep people safe. We created this self-service portal that's based in Salesforce where Rhode Islanders can schedule their own tests. They could look up their own test results. And if you test positive, we created a system where you could actually enter your own case information bypassing a phone call, including who your close contacts were and where you might have been when you were infectious or in your incubation period, so we can still do that cluster identification. We created systems where staff could send text messages. The system can auto text people who were named as close contacts saying, you've been named by somebody, you may have been exposed on this date and you should quarantine or you should seek a test. And we even used the system to notify international travelers that were returning to the US about our quarantine guidance and how to get tested. So bring services to people via technology. Salesforce has been an impressive tool for managing lab data and case data and also communicating with all of our different stakeholders.
I wanted to take a quick poll. I know we have a small denominator, but ask, is there anyone in this group who has not received a text message, used the portal to schedule a test, or gotten any of these automated services for COVID in the last year and a half, 2 years? Because I would be surprised if there's someone who has not interacted with Salesforce in some way. All right.
Jamie, I haven't.
Really?
But I don't leave my house, so I don't go anywhere. I've had no close contacts. I haven't, none of that stuff. So I have had no, I know I'm very familiar with it, but I just haven't had any, personal relationship with it.
Have you scheduled a test in portal.ri.gov?
Nope, through CVS.
Okay.
Mhm.
All right.
So,
All
yeah.
right.
You're an
But
anomaly.
I did help somebody schedule a test through the portal, so.
Yeah.
Thanks, Jill.
I keep using the wrong clicker. Okay. So Salesforce is phenomenal. Not only does it have routine case investigation and lab information, it could tell us when clusters are identified based on the findings of our case interviews. And it now has a log of all inbound calls that come to us. And we'll talk about the call center a little bit more. But we came from a space of call comes in, it gets transferred by a human being to somebody down the hall. They write something down on a piece of paper, they run it across the hallway, or they run up and down the stairs and hand it off. And then we respond to a completely electronic system using call center agents and call center technology and Salesforce to keep this log electronically, be able to query it, be able to share it with somebody, in this virtual space. So really enhancing our ability to serve people that are calling in and get information to the right people so that it could be responded to efficiently. And we could have an hour-long conversation about any of these topics because they are that cool, that interesting, and that impactful. Salesforce, just very briefly, like I said, can tell us when a cluster exists. So we created the system in a way where if I went to the Clam Castle to get some food, and then a day later, Jamie was there, and we both shared that information with our case investigator, and it was put into the system would alert and say, 2 people in the same time period were at the Clam Castle. There might be a cluster. And based on our own internal decisions, we could either respond to that or not respond to that. It's been huge in helping the employer team, the healthcare team, the congregate teams identify things. We had 130 case investigators doing interviews. There's no way one person can make a connection and realize, I heard somebody else was there 2 days ago. So the system is thinking for us and alerting us to things, and we can look at the number of associated cases and then respond appropriately. And the newest venture that we hope to get off the ground is Bluetooth notification system. So this is taking case investigation interviews and contact tracing totally out of the equation. It's a system that's used by at least 26 other jurisdictions around the country. And if I enable it on my phone and Jamie enables it on her phone, and we go to the same restaurant, but we don't know each other, and we're sitting back to back at tables for an hour and a half, and then one of us tests positive, and we say on our app or in our phone, I tested positive, it'll anonymously notify me because our 2 devices as proxies for us were within 15 feet of each other for more than, or within 6 feet of each other for more than 15 minutes. And so we can put in parameters there, and Bluetooth anonymous notification, it'll tell me, you might have been exposed to somebody with COVID, you should take precautions. And it really is, I think, the future, because we can't be doing all case investigation and contact tracing. There is COVID fatigue, but it might be a low effort way for people to say, I feel a little bit safer. And as school comes back in session and colleges come back in session and people start moving around more, it's an easy tool. You turn it on and then you forget you have it until you get that notification. Then you feel, I'm going to go take that self-test before I go to my family reunion, or I'm going to go take that test before I go visit my family member in the congregate facility. It really is probably, hopefully, a low-key way for people to continue to stay safe and respond to COVID.
Patty, apologies that I don't know this, but 401 Health app, and then the other one I want to make a plug for is the self-service portal.
Yeah, go for it.
Okay.
No, they're not in here. They're not called out specifically.
Okay. So for people who remember, Governor Raimondo very early on also created an app called the Crush COVID app, and it's still kind of, Crush COVID is still a phrase that we use all the time within our team. It has fond memories, and certainly is, we want to crush COVID, but it's also evolved now into a more holistic app for the health department called the 401 Health app. It allows people to schedule appointments. It also has access to your vaccine records. And what else? I don't have it up right now, but they are really building it out with full functionality and hoping to push out public health messages. I believe a message went out earlier today about the health advisory that's in effect today because the heat index will be so high. And certainly could be leveraged, Amy and team, for other emergency public health efforts. And then I believe they're integrating the monkeypox vaccine records within the 401 Health app. So certainly a ton of utility in the future there. So if you don't have that out, please download it because I think it is an important piece of technology. And then there has been a shift, certainly from PCR and facility-based testing to really making testing easy as possible for folks, including the proliferation of self-test kits, both at the pharmacies and then through our partner organizations. And so what we've done to try to help people who want to be good citizens and report to the Department of Health that they're positive, be able to report, and B, help us make connections with some of these automated cluster detection and then links and to be able to quantify the size of clusters is really have people report through a self-reporting portal that's open to the public. And then on the back end, we do some magic and link those things behind the scenes. So just wanted to encourage you to access that on our website or within the 401 Health app. There's a link there as well. And then let people that you know who test positive to also use that as a reporting mechanism for the Department of Health. Sure, it's not required. It's just good to help us understand the burden of disease within the state. Okay, Teddy.
All right. We have 11 minutes to go. After call center technology, we do deeper dives into our specialty teams. So I might pause there and just like really open it up unless there's crickets. But just wanted to call out that a major initiative and point of expansion and innovation with the response and with our center was creating a dedicated call center for COVID. So we have the 8022 general information line where FAQs, calls for clinical support come in. And that could be routed to our team, otherwise deflected, right? The hope is that you're calling about a common question that's on our website or that I can give you as the agent. I'm going to give it to you and you are going to get the information you need and be well served. But if you have a question about a medical situation or a complex question, we'll escalate it to a nurse. We also had a dedicated line for test scheduling and finding test results for our K-12 and our community members. We had a line for vaccine appointment scheduling. Sounds good. And so this advanced telecommunications functionality was computer-based. It allowed us to like staff up and staff down to align with call demands. We had great analytics on the number of calls per day, per hour, per minute, how long the calls lasted, how many people were waiting on hold. We could divert people just with hold music and information. So people dropped off the line and actually got served on the website or whatever. So very strong, very cool technology that hopefully will be integrated into more of the routine operations of RIDOH. But really, we couldn't have done the COVID response without this because the volume was just so high and so different than everything else we've experienced today at the health department. So wanted to give a plug for that one. And this is just the life cycle of a call in Salesforce. So education teams, congregate, employer, our field team going out into facilities, our QI support team, all of these are some slides there if people want to learn more. What we do with travelers to keep airlines and maritime vessels safe, how we support the vaccine or the immunization program and analyzing vaccine data, and we're getting to lessons learned. So I don't know, Jamie, if you want to take it or you want me to take it.
Go ahead, Teddy.
All right. So there are more lessons learned than I think we could cover, but COVID was on a scale unlike anything. So in COVID and in future pandemics, we need to prioritize scalability and responsiveness early to ensure that processes can adapt as needed. So both technology needs to be leveraged so that we can do more things with less and more efficiently, and operations, the way that we structure our teams and our human resources, need to be easily scalable up and down and flexible. We learned to leverage data to drive decision making. Where do we need to put test sites? Where do we need to put vaccine sites? What do people need? Where are there cases? Where are there not cases? Who's most impacted? Using data, so robust data analysis to inform decision making and prioritizing public health programs. At the same time, focus on the reality that there's humans behind everything that we do on our teams and the people that we're serving. So have a team that can educate people with empathy, that can build rapport, have a diverse workforce, have people that are culturally competent, have people that are multilingual, that can serve people without having to go through the interpreter line, and always be prioritizing excellent customer service, the trust. We rely on the trust of the public. If they do not trust us, they will not do what we tell them to do or what we recommend. So maintaining that trust and being a positive influence in our state is like really priority number one. We learned in our program to invest in a dedicated training and quality assurance program. This is not something that could be part of people's responsibilities and be done well. It needed to be centralized, dedicated, well thought out. So we emphasized tools like the phone system and Salesforce where we could do QA, and individuals dedicated to the activities of training people. And it's not just onboarding and first-time training, it is ongoing education, because every week CDC changed something. We always had to be changing with the new guidance. And then this was an emergency response, but we're 2.5 years later. And so it's never too early to invest in developing a team identity and a cohesive culture. Jamie and our prior chief, Christine, emphasized creating a mission, creating a newsletter, building team identity, building team cohesion, having daily or 3 times a week huddles, bringing people together, particularly in a hybrid or a remote work environment, to keep that human connection. It is much easier from an organizational standpoint to keep people than to hire and train new people. And that's just the business end of it. But more importantly is teams work better when they trust each other, when there's psychological safety, and when people want to do what they're doing. And I think in an emergency response, you can throw all that out and say, we just got to respond to the fire. But the fire has been going for 2.5 years now. And I think we're very fortunate that there was early thinking around building that cohesion. So
Around
those
that
are,
point, Teddy, I'll
yeah.
just add that we're still a fairly large team. We have about 150 people still working within the center, and we have always been in flux from a organizational structure and like kind of our team members.
Yeah.
But one of the things that I'm most proud of, because we put an emphasis on culture, training, really bringing people along, is there have been a tremendous number of people that have found permanent homes within the health department. So I was in Pridem's in Suite 101 early this week and was walking through and just saying, I know you, I know you, I know you, I remember you. So I'm just the public health workforce that we've been able to bolster here, and I think taking even people that were not necessarily interested in public health, who said, I'm going back to get my master's degree, or I want to continue to do this type of work. This is really fulfilling, I think has been a silver lining of this very difficult period of time. So something that we're particularly proud of and continue to foster that culture and that teamwork, even with contractors who work for us and have been with us for a long time. We've had a lot of committed, really dedicated people with us. So they deserve all the credit as well for our successes. So I think that's the end of our presentation, and we'll pause there. We just have a few minutes left We'll let you peruse the slides for the additional content about the specialty teams after the presentation is over. But certainly, if there are questions, we would love to answer them for you. So we'll just pause there. Anything strike you? Is anything that we presented surprising, or you didn't know, or just kind of looking for general reactions about the content? If there's something missing too, if we do this in the future, please let us know and give us feedback.
Yeah, is there anything that you're like, I thought I was going to learn about this, or how does this work? You didn't touch on it. Anything like that?
Rachel, I'm going to pick on you as an epidemiologist. If you were looking for, if you were looking for data, that's a whole different presentation from the quant team. Certainly could. I think what is of interest is really we are the front end of that whole population-based surveillance system, and our team collects all of the data that goes into producing all of the dashboards, all of the public-facing information. But certainly that we use that information to drive our outreach as well. So it's kind of, we are very well connected to the quant team and the work that they do on a regular basis.
Yeah, I have no feedback. I thought this was a phenomenal presentation. You guys explained everything so transparently, so clearly. And it was so interesting to learn the behind the scenes. I actually worked in COVID units in New York when we were the epicenter. So for me, this was so interesting to see a different side of things for COVID.
Did you work for a contracted agency, or did you work for the health department?
No, so I worked at Memorial Sloan Kettering Cancer Center in New York. I was a senior coordinator there for 3.5 years.
Okay.
So when COVID hit, I ended up running COVID units myself.
Oh, the COVID unit. Okay,
Yeah.
within the hospital. Okay, wow.
Yes.
Wow.
Yes, very difficult. And then I was starting my master's program. So quite the experience to learn public health while doing public health.
Yeah, we have said to some of our undergraduates, you now have a master's in public health.
Yeah, it sure feels like that for everybody that's been through this.
Sure.
I want to, with Amy being on, I want to say that there is, I believe, unless I moved it, but a bullet point that recognized our collaboration with the Rhode Island Special Needs Emergency Registry and thinking about how to connect all of the information that we had in COVID and who was vaccinated and who wasn't vaccinated, who could benefit from outreach with the Reisner data set and try to like best serve people. And that was, I think, an example of like crossing teams and programs, building connections where connections maybe previously didn't exist. And there are tons of examples of that too. And they'll probably persist for a long, long time. Jamie says, you know, in Salesforce, we have like a registry of the entire state of Rhode Island because of how, how prevalent, COVID has been and how many people have been impacted either in test scheduling or testing positive or being vaccinated, that we can do really interesting things with our data appropriately to like understand the state of health in Rhode Island. So.
You can't tell. Teddy and I love this work. We love that it's changing all the time, and it's like a puzzle that we have to figure out how to put together in real time, and are looking forward to the next phase of whatever unfolds. But if you have more questions, we're 1 minute over and don't want to be respectful of your time. So I guess we'll end here, Jen, but certainly reach out if you have additional questions. Happy to answer them because we love this work and we're proud to share what has transpired.
Thank you guys so much. This is amazing. As someone who was kind of with you guys for about a year, it's just really great to see where things have gone since I left. And it's just awesome to see the data and everything behind it. Because, I mean, we were so in it at the time that, that's all I knew was the logistical pieces happening in the background. Yeah, so it's really awesome to see everything kind of put together in this presentation. It was really great.
It really, I mean, we could do this every day or twice a week for the, next 6 months, and like logistics itself is hours of
It's a story.
discussion about how the heck we did that. It wasn't touched on here, but behind all of our operations is a logistics team keeping things running and getting us people. And yeah.
Thank you guys so much. It was great.
All right.
Well, thank you
Hope
all
to see you all
for
soon.
listening.
We're lucky to have
Yeah.
your leadership, Jamie and Teddy. We very much are.
Thanks,
Thank
Jill.
you. All right. Talk to you all
All right,
soon.
bye everybody.
Bye-bye.
Have good days. See ya.